Welcome to the first mini lecture in the Pharmacotherapeutics series. And I just want to lay the foundation for everything that follows. So what we're going to do is we're going to define some terms, especially allopathy, and introduce some of the basic ideas of pharmacodynamics and pharmacotherapeutics. And we're going to start thinking like clinicians. So we don't just see symptoms, but we ask what medications might be contributing to the entire picture. In other words, how is a person responding? So if we're looking at the figure, of course, the first thing that leaps out at us is that dinosaur. And that image is actually a memory aid. And the dinosaur was called an Allosaurus because it looked different from other lizards. And that gives us a way to remember the term allopathy. So allopathic medicine refers to modern science-based medicine where medications or procedures were used to counter the symptoms or the effects of the disease. And so in this lecture series, we're going to keep returning to two major ideas. First, what do drugs do to the body? And that's pharmacodynamics. And then what does the body do to drugs, which is pharmacokinetics? So that'll kind of be the hallmark or the framework that we put ourselves in as we're looking at this series of lectures. So when we talk about allopathy, we're talking about the underlying paradigm of modern medicine. And so it's the use of substances or interventions to treat disease. So on this slide, I also want to review the prevention framework, and that is primary prevention, secondary prevention, and tertiary prevention. And primary prevention means we're trying to stop the disease from occurring in the first place. For example, through vaccinations or elimination of harmful exposures like removing asbestos or lead paint, right? Trying to prevent the disease from ever happening. Secondary prevention means we're catching the disease early. So we're using screening or tests to identify the disease is present, but we're hopefully doing that at a point in time where with certain prescriptions or certain treatments, we can maybe reduce the negative effects of the disease or try to prevent it from spreading or eliminate it altogether. And then tertiary prevention means the patient now has the disease and we're trying to limit as best we can the progression. In other words, we're trying to reduce the impact. And that might be something like cardiac rehabilitation, right? The patient has already had a heart attack, they're already in the clinic, and now they're undergoing cardiac rehab to kind of stave off the underlying negative impacts that they may be experiencing. Now, if we think of DOs, Doctor of Osteopathic Medicine, right? Those are similar in practice to MDs. And so we have a number of different clinicians that might be kind of engaged in this allopathic medicine. So some of the parameters of pharmacodynamics. So pharmacodynamics asks a very straightforward question. What does the drug do to the body? Okay, so let's say a physician gives an antihypertensive medication. The desired response, of course, would be a reduction in blood pressure. But at the same time, there could also be undesired responses, such as dizziness or upset stomach. And so this is where we have this understanding of how drugs operate. And we say they bind to receptors. They act as ligands. And they initiate signaling pathways. Now, we're kind of familiar with this premise because we understand endocrine glands secrete hormones. Hormones bind to receptors and initiate a cascade of events. Well, drugs operate the same way. And so what we're looking at is the pathway. And sometimes the pathway can cross over to other systems where this can explain some of the side effects. So pharmacodynamics also helps us understand why two patients may respond differently to the same drug because genetic variation and age and immune response, tissue specificity, these all influence the final effect. So when we look at individuals, we have a similar genome, but there are slight differences that make us all unique individuals. And so understanding this idiosyncratic response, this is, further illustrating some of the variation in pharmacologic response. And so think of idiosyncratic responses just as an unpredictable, not explained by the pharmacologic properties of the drug, event, right? An example would be an individual with infectious mononucleosis, right? They develop a rash when they're given ampicillin. Now, ampicillin is a penicillin type antibiotic, and it's used to treat a variety of different bacterial infections. So a rash develops, right? An idiosyncratic response can sometimes be leveraged for therapeutic effect. A stimulant, right, could be used with attention deficit disorder or hyperactivity disorder. In fact, the stimulant could reduce distraction and increase or hyperfocus concentration. And toxicities and side effects, right? The amount of drug that's building up in the body. Now, this could be due to defective clearance, right? The body is not getting rid of the drug and it's staying in the system and it's continuing to bind and it's continuing to have an effect. Or it could be over-consuming the medication. Maybe the dosage is too high or the dosage is too frequent, right? Tissue specificity, like where it's being stored. Is it being stored bound to, the hemoglobin in the blood, or is it being sequestered in the fat where it's kind of staying present? And then polypharmacy. And this is especially common in older adults where we're looking at drug interactions. Some people taking 2 and 3 and 5 medications, right? They might have competing effects. So medications are all trying to bind to the same receptor. And they may have similar effects, or that may exaggerate a response, right? And so we're kind of considering all of these factors when we're looking at pharmacodynamics. So what do drugs do to the body? So one of the most practical habits you can develop in patient care is asking about medications early. So what is the patient taking? What are the common drug interactions? What are the problems that can show up? Let's say agents like warfarin or digoxin or phenytoin. Athletic or active populations, right? Are they going to run into issues such as antibiotics decreasing the effectiveness, maybe of oral contraceptives or migraine medications interacting with certain antidepressants? So if somebody's presenting with dizziness or drowsiness or a new chief complaint, right? The thing is to not automatically assume that the disease is the whole explanation. Ask whether a medication was recently started, whether a dose changed, whether a dose was missed, right? These can all be factors kind of contributing to a patient's medical history. So medication history can completely change how we interpret the scenario, and really diving into those questions with the patient is going to help to further their continuity of care. So I think the big takeaway from this first segment is simple. Pharmacotherapeutics is not just a list of drugs. It's a way of thinking about how medications alter physiology. So why patients respond differently and why careful medication history matters before we interpret signs and symptoms.